Good morning, fellow nurses. Thanks for coming to today's ER staff meeting where we're going to be discussing the rollout of the new ER harm reduction model and how that plays into ER discharge instructions. This is based on my Practicum education project for my BSN, as many of you know. So we're just going to be going over this and discussing what this is, what it means for you, and how this will change things and have an impact on our community. So what is the change? So let's just talk about some basics here in the background of what's going on. So I think, as we're all well aware, this is in response to the spiraling opiate overdose rate in our community, particularly in Ashland, but in Jackson County overall. Our community is pretty small, tight knit. In many ways, we are socioeconomically very privileged, but this affects a lot of people from all walks of life. And I think we've all seen this in multiple shifts that we've had of people coming in, either actively overdosing on IV opiates or experiencing other large range of health conditions that are exacerbated by or directly caused by IV opiate use from our patients. So this is a huge issue. And one way of combating this, one way that we can directly affect change in our role as ER nurses is by changing discharge education for IV opiate users, for our target population. So how are we going to do that? Well, we're going to base it on evidence, and we're going to keep it pretty simple. Our jobs are really complex and difficult, as we all know. So let's just keep this as simple and basic as we can, and based on evidence, as we know is a huge important part of what we do. So this is really going to be centered on a pamphlet of resources that are based on the idea of harm reduction. So we're going to get into harm reduction a little bit later. It's going to utilize teachback, something that a lot of us already do in our education, not always, but this new education piece in particular is really going to be based in that. It's going to require a little bit of slight change in our documentation, but not much. I know we already are saddled with quite a bit of responsibility as far as documenting in the health record goes, and I don't want to add to our burden unnecessarily. And then we're going to evaluate that. We're going to evaluate this officially in February, but we're going to be doing that on an ongoing basis as well, which really dovetails with our roles as nurses as part of the nursing process. So objectives for today in our staff meeting. So number one, what we want to do is demonstrate the use of the teach back method in providing patient education. We'll do a little role play. We're going to implement documentation requirements by going over new sections on the electronic health record, EPIC in our case. And we're going to present the information to our patients and be able to discuss the resources with them. And by that, I mean, we're going to go over the pamphlet today, make sure that everybody understands what those resources are and how we can best direct our patients toward them if they are showing any interest. So, little pre-test. If you guys want, there's paper and pens that I've passed around, so you can take those and just jot your answers down to this really quick. Number one, what is teachback? How can you use it during discharge education? If you already use it, go ahead and write down an example of the ways in which you do. Question number two, how are we going to document the new discharge education for this target population? So, probably you don't know that yet. Go ahead and put your best guess or maybe what you think it might be. What are the existing community resources that provide harm reduction services? That's question number three. So go ahead and write down your answers to those. So moving on, let's talk more about this project. So why is this change happening? Again, there's been a major increase in opiate overdose rates this past year in 2018, which I know we've talked about in previous staff meetings, so this is not a surprise. The ER is a great place and an opportunity to intervene in risky behaviors, including drug use. This is backed up by multiple recent studies. This one referenced here was in the Annals of Emergency Medicine from this year. I think we're all pretty aware that there's a large population of our clients that use the ER as their place of accessing primary care, which puts us in a really good position to intervene and provide assistance with a lot of the needs that they come to us with, not just opiate overdose or opiate misuse disorders, but a lot of other issues too. And that gives us a very useful, helpful segue into talking about some of those bigger problems that they might encounter, including overdose and death. Um, and, this really is grounded in our responsibility to care for our patients. We advocate for them. That's what we do as nurses, and what we as a group of ER nurses are so spectacular at is providing direct care to people, regardless of their background, their socioeconomic, sociopolitical, cultural, background, where they're coming from. We just meet them where they are. And we do our best to do that without judgment. Our number one job is being patient advocates and keeping people safe, or at least as safe as we possibly can. And that really comes into play when you're talking about risky behaviors like IV drug use. So one of the ways that we can do that is by following nursing theories, and there's a particular health promotion model um, that goes over that. It really dovetails nicely with harm reduction and providing care to patients from all backgrounds. It talks about how nurses have a very effective role to play, and they can really influence the choices and the actions of our patients. So it's very important. Harm reduction is this idea that uh, even though humans often choose to engage in really risky, detrimental behaviors like IV drug use, like having sex with frequent partners without condom use, without birth control, any number of risky behaviors that we engage in. Harm reduction is the idea that even though people are engaging in those behaviors, we can do our best to make it safer for them. So, to use the idea of sex with multiple partners, we can advocate that people use condoms. We can advocate for frequent STI testing, pregnancy testing. We can advocate for low cost or free access to birth control. And then we can apply that harm reduction model to IV drug users as well. So, these are people from our community who, for one reason or another, are using intravenous opiate drugs. And it research shows that it's actually far less effective to try and use punitive measures or to just force these people into treatment when that's not where they're at right now. So, harm reduction is that idea that we make it somewhat safer for these people. And one of the ways we can do that is by connecting them with resources that already exist in Jackson County. There's a syringe exchange program. So, people who are already using, intravenous drugs can take their syringes and needles. They can take them into the syringe exchange program, and for no cost, they exchange. Say they have 10 needles, they give those needles over to the staff at the syringe exchange, and they receive 10 sterile needles. Okay, so they get as many back as they bring in. It has to be an equal number. Reason being that they don't want these syringes to be discarded on the street where they could then maybe a kid could step on them or something like that. So it's a way of keeping the community safe as well. As these folks access needle exchange and syringe exchange programs, they actually as well get information on treatment. So it's a point of entry where they can get non-judgmental harm reduction care, but they can also access other things as far as drug cessation programs, things like Suboxone and methadone treatment, other social services that can help address some of the bigger social issues that may play a role in the drug use as well. So harm reduction in a nutshell is really that approach of being non-judgmental, of meeting people where they are, understanding that they're engaged in some pretty risky behaviors, and coming up with ways to sort of mitigate that risk. So that's what this project is based on. This is completely supported by evidence. So I have two references here, and I would be happy to pass those around when we're done if anyone wants more information on that. But this is something that's been implemented in large cities like San Francisco, Seattle, Philadelphia. There's a lot of places who are really seeing the benefit of this approach, and they're seeing some major improvements there, which obviously is important in nursing to have a very solid research background, and this is very well supported. And improving discharge in education can have a really positive impact on this community. I mean, I think we're all aware of how beneficial good quality education can be and our role in providing that. So it's really going to be beneficial, I think, to work this in what we're already doing and just improve it a little bit. So one of the ways that we're going to do that is by relying on this solid idea of teach back. So it's an evidence-based process for educating our patients. It's a way of talking to someone and getting them to teach back to you the information that you've just given to them. And that's a way that you can assess understanding and comprehension of that person that you're trying to teach. So, if you're teaching about, let's say you're teaching about wound care, someone's just received sutures, and you are talking to them and you say, okay, well, you need to keep this wound clean, keep the dressing dry, make sure you're looking for signs of infection every day. Signs of infection would include red streaks, green drainage, an increased temperature, or significantly increased pain. Now, why don't you, in your own words, tell me what you're looking for when you're checking for signs of infection in that wound? And then the patient would say, well, I would look for this, 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 and this, or they might tell you something completely off the wall that lets you know, okay, they didn't really understand what I told them. And then you can, alter your education or change it a little bit or, make it more focused depending on what you're hearing back from that person. So that's teach back in a nutshell. And we can use that in any sort of education that we do. And it can be really effective, especially in the realm of harm reduction for some of our patients who may have some issues with learning and retention anyways. So let's go over that a little bit more, but first let's talk about our resources. So this is a copy of that pamphlet that we're going to be using. It's pretty small on this slide, and I've passed that around to all of you as well, so you'll have that in your paperwork there on the table in front of you. So we'll take a look at that. So let's role play this. Let's use that handout. We're going to break it off into groups of two. So one of you is going to just play yourself, play the ER nurse, and then the other one is going to be a patient from this vulnerable community. So the other person is going to be an IV opiate user who's in the ER for something, whether it's overdose or abscess drainage or whatever. They're there and they've been identified as an IV opiate user, and so now we're in the process of discharge. So using that pamphlet, I want you to go over that together. The RN, go ahead and do your teaching, and then we'll have the other person go ahead and do that teach back and try that out and see how that works. Okay, so that was great. Let's move on. We're going to talk about the change in documentation. It's going to be pretty slim as far as changes go. But as the nursing process tells us, we have to evaluate after every intervention, right? Assess, diagnose, plan, implement, evaluate. So that we are now implementing, and then we're going to be evaluating it to see if it works. So this is no different than the rest of the nursing process. In order to evaluate, obviously, we got to collect some data. And the way that we do that is by changing the documentation slightly so that we have some data to evaluate. So the changes include 2 buttons, that's all. So one at triage when you're doing your screening for substance use, just click the box. And then the other one is at the end of discharge where you go in to say date, time, discharged where, with whom, what kind of education was provided. And there will be a built-in button that IT is going to place into Epic, and it will say, harm reduction education done. And you just click the button. And then that will be linked with the initial button from triage so that when those folks are identified in triage, that they're getting that discharge education piece. And then when IT goes back 6 months later to run that report, it will tell us how many times the discharge teaching was done in regards to a positive triage screening. So the goal is 90% of those patients who are identified as IV drug users will receive this education at the end of discharge. So, and then if there's any other ideas that you have as we go along, obviously that's always welcome. We're a small department. I mean, we all get along really well together. I would hope that you all would feel free, coming to me with changes or feedback or any of that, and we can talk about that later too. The official timeline to evaluate this is going to be February 1st of this upcoming year. So August 1st is the go live date. Those exact pamphlets that you have in your hand, those are going to be copied and stocked at the nurses station. It's going to be very easy to find. I will personally be responsible for photocopying and stocking these, so let me know if we run out. Um, the buttons will be ready to roll too by August 1st, so all this is going to be ready to go. And then in February, we're going to evaluate it. So we'll pull that report from IT to evaluate whether or not we met the 90% goal. And then I'm going to give you guys a short survey that you can report feedback on the project as well. And then we'll talk about that at the staff meeting in March. You can, like I said earlier, you can always talk to me if there's feedback or suggestions. Michelle, as well as our manager, is another great resource to talk to. And then Dr. Barone is fully on board with the project and is always open to comments as well. And if you just don't feel like talking about it or letting me know, or if you have a complaint about it and you don't want to put your name on it, that's fine, because I'll put a separate folder in my inbox. You can put a note in it when I'm not here. Don't sign your name and I won't know who it's from. So we've circled back around to the post-test. These are the same questions that we talked about earlier. So if you guys just want to take a minute and write down your answers to those, and we'll go over those. Okay, great. I just want to say thank you for being such awesome nurses who give such good care to this community. I love working with you all. I know that you all really care about what you do, and you care about the safety of this community because we all live here. And the impact that we make can circle around and be a really big impact on our own families and our own lives. So thank you for being dedicated to what you do, and for embarking on this journey with me. Thank you. Here's a list of references as well. If anyone wants a copy of this, I'd be totally happy to print it off and give it to you.